Hello, my lovely nurses. I hope you are fine and your family is good. Today, our topic is cholecystitis. Cholecystitis means the inflammation of the gallbladder. So, be with me because we will discuss this cholecystitis full topic. The what is cholecystitis? We will talk about risk factors. We will talk about the assessment. We will talk about what intervention as a nurse we should have to do, and we will talk about how we will manage the pain. This is a very important topic because in exam the questions are coming about this cholecystitis topic. So watch the video from starting to end so you will understand completely about this topic and all the criteria. So our topic is cholecystitis. So cholecystitis is acute or chronic gallbladder inflammation. Cholecystitis, acute or chronic gallbladder inflammation. Now, what is cholelithiasis? Cholelithiasis. Cholelithiasis mean is gallstones. So gallstones, what gallstones will do? They will obstruct the bile duct. They will obstruct the bile duct. Now, if the bile duct is obstruct, what will happen? The bile back up. If the gallstone will obstruct the bile duct, the bile will be back up. And if the bile will be back up, what will happen? The gallbladder becomes distended and inflamed. So cholecystitis is acute and chronic gallbladder inflammation, and cholelithiasis is gallstones. If the gallstones is there, it will obstruct the bile duct, and once the bile duct will obstruct, bile should be back up, and if the bile should be back up, gallbladder become distended and inflamed. This is the complete definition of the cholecystitis and cholelithiasis. Now we will talk about the risk factors. What risk factors? So risk factor is high fat diet. If patient is taking high fat diet, keep in your mind 3F. So it's easy to understand. Number 1 is high fat diet. Now you will keep in your mind 3F. Number 1 is female. Females have the great high risk for the cholecystitis. Number 2, fat. Fat mean obesity. Number 3, F is 40. 40 mean the age more than 40. Age more than 40. The 3F, very easy to understand. The high fat diet, the patient who are taking high fat diet, and the keep in your mind 3F. Number 1, female, fat, and the 40 age, the age is more than 40. Now we will talk about the assessment. How we will assess the patient have cholecystitis or no. This is very important. Maybe the MCQs are coming in the exam. The which side of the abdomen, they will maybe give you the 4 sides, right upper quadrant, left upper quadrant, this like this they are give you the 4 sides, and you have to take the correct one, which side the patient is mostly feeling the cholecystitis pain. The assessment, the first assessment is the right upper quadrant pain. Right upper quadrant pain, patient will complain right upper quadrant pain that radiates to the right shoulder. That radiates to the right shoulder. So this is the main assessment, the right upper quadrant pain that radiates to the right shoulder. Number 2 assessment, patient will complain the pain triggered by high fat. The pain is triggered by high fat meals. Mean if patient is taking high fat meals and the patient pain will be triggered by high fat meals, the fat stimulates gallbladder contractions. So once patient is taking the high fat meal, the fat is stimulates the gallbladder contractions. So that's why patient is feeling pain when he is taking the high fat meal. Then patient have nausea and vomiting. Nausea and vomiting. Very important, Murphy sign. Murphy. The Murphy sign. Murphy sign mean pain when palpating right upper quadrant during inhalation. Once the doctor will assess the palpate the right upper quadrant during inhalation, patient will feel pain. That is Murphy sign. The pain when palpating right upper quadrant during inhalation. So doctor will palpate the right upper quadrant and during inhalation patient will feel sudden pain. That is Murphy sign. This is the most important sign of the cholecystitis. Then steatorrhea. Steatorrhea mean undigested fat in the stool. Undigested fat in the stool. Steatorrhea. Then patient have fever plus increase white blood cell count. This is the assessment. Right upper quadrant pain that radiates to the right shoulder. Very important, pain in triggered by high fat meals because the high fat stimulate the gallbladder contractions. Nausea and vomiting, this is very important, Murphy sign. They will give you maybe the 4 signs and they will tell you which sign is related to cholecystitis. The Murphy sign. What is Murphy sign? Once doctor will palpate the right upper quadrant pain during inhalation, the patient will feel pain. That is Murphy sign. Steatorrhea, undigested fat in the stool, and fever, increase white blood cell count. Now what intervention as a nurse we have to do? The intervention, the first, prepare client for abdominal ultrasound. The first is prepare patient for the abdominal ultrasound to diagnose cholecystitis. So first we will do abdominal ultrasound. If the patient is stable, supportive treatment. If the patient is stable, manage with the supportive treatment. What is supportive treatment? IV fluids, analgesics, antiemetics. This is the supportive treatment. But if patient is unstable, what we have to do? If patient is unstable and the supportive treatment is failed, a cholecystectomy may be required. Cholecystectomy may be required. What is cholecystectomy? Removal of the gallbladder. Now the cholecystitis care, focus on what we have to focus on cholecystitis care. Number 1, manage pain. Number 2, hydration and nutrition, the IV fluids, hydration plus nutrition. Number 3, monitoring for peritonitis and shock. Peritonitis and shock. I will discuss later this one. So monitor for peritonitis and shock, and prepare for cholecystectomy or other procedures as needed, like ERCP we are doing for the removing of the gallbladder stone, or cholecystectomy, removal of the gallbladder. So prepare patient for the cholecystectomy or any further procedure. Now support, hydration and nutrition. What's the meaning of support, hydration and nutrition? In the support, hydration and nutrition, we will give IV fluids, and then antiemetics like ondansetron, we are giving Maxolon. So antiemetics. We will insert the NG tube for severe nausea and vomiting. If patient have severe nausea and vomiting, we should have to insert the NG tube. For clients with chronic cholecystitis, provide dietary teaching. If patient have chronic cholecystitis, in the acute cholecystitis, IV fluids, antiemetics, NG tube, analgesics. So this is the supportive treatment. If patient have chronic cholecystitis, in this situation, eat high fiber, low fat foods. This is very important. In the question they can ask you which type of diet is recommended for the cholecystitis patient. So which type of diet we will give? Eat high fiber and low fat. Eat high fiber and low fat foods, and eat small frequent meals. Eat small frequent meals. Instead of they will eat the heavy full lunch or meal, no need to take the full meal. Eat small and frequent meals. That is good for the cholecystitis patient. Now how we will monitor the peritonitis and shock? Very important. How we will monitor the peritonitis and shock in cholecystitis patient? So an inflamed gallbladder can rupture. Inflamed gallbladder can rupture, releasing bacteria that irritate the peritoneal lining. So once the gallbladder will rupture, what will happen? They will release bacteria, and the bacteria, what they will do? They will irritate the peritoneal lining. Irritate the peritoneal lining. So inflamed gallbladder can rupture. Once it will rupture, they will release bacteria. The gallbladder will release bacteria, and they will irritate the peritoneal lining, causing peritonitis and shock. So inflamed gallbladder can rupture. After rupture, it will release bacteria, and these bacteria can irritate the peritoneal lining, and what will happen? Causing peritonitis and shock. So now if the patient have now peritonitis and shock, we will monitor for peritonitis. How we will monitor? The patient abdomen will be rigid, board-like abdomen. Rigid and board-like abdomen, and abdominal guarding. Abdominal guarding means patient will hold the abdomen. Once the abdomen is rigid, board-like abdomen, you will see patient is holding the abdomen, guarding the abdomen. Rebound tenderness. So rigid, board-like abdomen, abdominal guarding, rebound tenderness, and if the patient have shock, patient have increased heart rate, tachycardia, and decreased blood pressure, hypotension. This is the shock sign symptom, tachycardia and hypotension. Now, if patient have peritonitis and shock sign symptoms, we will prepare the patient for the cholecystectomy. And after cholecystectomy, what nursing consideration we should have to perform? The following laparoscopy: ambulate as soon as possible. Ambulate as soon as possible. Why we will tell patient to ambulate as soon as possible? To promote gas reabsorption and reduce shoulder pain, because during cholecystectomy we are insufflate the abdomen with the gas. So what gas? This gas will make a problem. It will make the shoulder pain. So to reduce the shoulder pain, we will encourage the patient to ambulate as soon as possible. So the shoulder pain that is associated with trapped this laparoscopy gas, so encourage deep breathing exercise. We will encourage the patient to prevent this atelectasis and pneumonia. If patient will not deep breathe exercise, he will not use spirometer, so what will happen? The patient should have the pneumonia problem or atelectasis problem. Monitor output. If report if the patient have drain, we should have to monitor the drain. The total intake output we should have to monitor. To if the patient have any purulent drainage, we should have to inform the healthcare provider. Laparoscopic, if the patient have laparoscopic cholecystectomy, and the word discharge teaching we should have to provide to the patient. Resume normal activities including work within 1 week post-operatively. Very important. Gradually add fat back into the diet as tolerated. Frequent and the small meals. Try to avoid the high fat diet. Never tell the patient to stop the fat, but as tolerated, normal fat, not the high fat diet. And we will encourage the patient to take the fiber diet. Can shower 1 day post-operatively. Report signs of infection if any purulent drainage or erythema, the redness or purulent drainage on the incision sites. If cholecystectomy is not indicated, the cholecystectomy, sometimes the patient no need cholecystectomy, we should have to remove the gallstone. So how we can remove the gallstones? The ERCP is endoscopic retrograde cholangiopancreatography, that is ERCP, or via lithotripsy we can remove these gallstones. The ERCP is endoscopy. What is ERCP? In ERCP, what we have to do, it visualize the bile duct, and the doctor can remove the gallstone. Maintain NPO status 8 hours before ERCP, because we are giving sedation or maybe sometimes GA, and the keep NPO until gas reflex will returns. This is very important. Monitor for signs of perforation, abdominal rigidity and tenderness, that I told you, the peritonitis and the shock sign symptoms, because this peritonitis can make more problems for the patient. So what we have to know, the right upper quadrant pain, patient will complain right upper quadrant pain that radiates to the right shoulder. And the risk factors we will keep in our mind: the high fat diet and the 3Fs. The more high risk patients are females, and the fat, the obesity and the age more than 40. 3F female, the 40, the age more than 40, and the fat, the obesity patients. These are the high risk for the cholecystitis. And we will monitor the patient for the peritonitis and shock. The peritonitis sign symptoms, we have to know the abdominal rigidness, abdominal guarding, and the rebound tenderness. And for the shock, tachycardia, hypotension, this is very important. As a nurse, we should have to know these all sign symptoms, so we can manage the patient accordingly. If the patient have peritonitis sign symptoms and this one, the shock sign symptom, we will prepare patient for the cholecystectomy. And after cholecystectomy, the nursing consideration that I already discussed with you is very important. Ambulate the patient as soon as possible, breathing exercise, pain management, prevent from the infection. So this is all important points. Always go through the ABCs, airway, breathing, circulations. If the in the questions ABC's option is not there, we will give priority to the pain and the infection. If the patient sign symptom is not related to peritonitis, patient is stable, supportive management with the IV fluids, antiemetics, analgesics. If the patient is not stable, the supportive sign symptom is not is failed, is not patient is not improving through the supportive management. So we have to prepare the patient for the cholecystectomy or either for the ERCP or the lithotripsy. I hope you like the lecture. If you like, please share and subscribe my YouTube channel, and don't forget to push the bell button so you can receive my coming videos notification. Thank you very much. Take care of yourself and your family. Allah Hafiz.